Well, it's 3 o'clock and it's the top of the hour. Welcome everyone to the Housing and Services Partnership Accelerator, Emerging Findings to Strengthen Housing, Health, and Social Care Partnerships webinar. We're really excited about today's conversation. Next slide, please. My name is Ryan Elza, and I'm the Interagency Housing Innovation and Strategy Lead within the Office of Interagency Innovation at the Administration for Community Living, which is an operating division within the U.S. Department of Health and Human Services, and I will be serving as today's facilitator. Next slide, please. First, we just wanted to review a few housekeeping notes. Please use your computer speakers or dial in using the phone number in your registration email. Please note that all participants are muted. Please feel free to actively use the chat throughout the webinar to make comments or connect with other participants. To ask a question that might be answered during the Q&A section, please use the Q&A function on Zoom. This will allow presenters to easily find your question. And you can also send your question or comment via email to hsrc@acl.hhs.gov. Someone will be monitoring the HSRC inbox throughout the webinar. And please note that this event is being recorded, and by staying to participate, you're agreeing to participate in the recording. Next slide. And a few notes on accessibility. We will have ASL interpreters pinned throughout the webinar. To enlarge the view of the interpreter, you can click on their window and select the pin icon to maximize your view. For screen readers, if you'd like to reduce unwanted chatter, you can request speech on demand by hitting the Insert key, spacebar, and the letter S on your keyboard. Next slide. The Housing and Services Resource Center, or HSRC, was launched by the U.S. Department of Health and Human Services and U.S. Department of Housing and Urban Development in 2021. The HSRC fosters cross-sector partnerships between the organizations and systems that provide housing resources and homelessness services, healthcare and mental health services, independent living services, and other supportive services. The HSRC is part of an interagency initiative to streamline and expand access to affordable, accessible housing and the critical services that make community living possible. Our federal HSRC partners launched the Housing and Services Partnership Accelerator, or the HSPA, a major new initiative to align housing, health, and social care. Next slide, please. In a minute, I'll turn it over to our federal presenters for opening remarks to share how housing, health, and social care is being brought together at the federal level and celebrate the progress made in the Housing and Services Partnership Accelerator. Then you'll hear about the goals of the accelerator and how states are being supported through this federal TA opportunity. Next, we'll hear from Arizona, the District of Columbia, and Hawaii about how the accelerator is helping them strengthen collaboration across Medicaid, housing, aging, and disability, as well as implement innovative strategies to help people at risk of or experiencing homelessness obtain and maintain stable housing and supportive services. We'll leave some time at the end for some brief Q&A with our state panelists. So please drop your questions in the chat using the Q&A function. We will try to get to as many questions as we can during today's webinar. Finally, we'll close out with some HSRC resources to inform states, to inform other states' work as they strengthen their housing, health, and social care partnerships. Next slide, please. And with that, I will turn it over for opening remarks from our federal presenters. So first, we'll hear from Allison Barkoff, who leads the Administration for Community Living. Then Allison will turn it over to Dr. Richard Cho, who's the Senior Advisor for Housing and Services at the U.S. Department of Housing and Urban Development. And Dr. Cho will turn it over to Dr. Jessica Lee, who's the Acting Chief Medical Officer for the Center for Medicaid and CHIP Services. And with that, I'll turn it over to you, Allison.
Great. Thank you so much, Ryan. And as Ryan said, I'm Allison Barkoff, and I have the privilege of leading the Administration for Community Living. And for accessibility, I'll give a quick visual description. I'm a middle-aged white woman with curly brown hair, wearing a blue dress, and I'm in my ACL office with a flag behind me. And I am so excited to be a part of this first national webinar for the Housing and Services Partnership Accelerator. And it is really incredible to see the way that federal, state, and community partnerships are taking off around coordination of affordable, accessible housing and community services. As Ryan said, today we're going to feature the successes of this first cohort of states and describe strategies that you can leverage in your own communities. ACL is all about partnerships. Working together is the only way we can begin to address complex problems like homelessness and housing instability. And ACL could not have better partners in this work, including my friend and colleague Richard Cho at HUD and Jessica Lee at CMS and our colleagues at SAMHSA and a number of other federal agencies. You all deserve so much praise for making this learning collaborative possible. And I want to give a special welcome to the 8 states and the District of Columbia who are joining today's call, the first cohort of participants in the Housing and Services Partnership Accelerator. We're already seeing innovative ideas for coordinating housing and services and such a strong commitment to current and future partnerships. This work, building on partnerships, leveraging all resources, and thinking outside the box about coordination of housing and services is critical to making real progress on addressing homelessness. Of course, the lack of affordable, accessible housing is the primary cause of homelessness, but we know, and all of our shared reality is that many people experiencing or at risk of homelessness are people with disabilities, older adults, or people with behavioral health needs for whom housing alone is not enough to keep them stably housed in the community. Richard Cho and I connected to talk about partnerships within the first days of our new jobs at the beginning of the Biden-Harris administration. And we knew that without wraparound supports and other housing-related community services, we would never achieve our shared goals around housing stability and ensuring full community participation for the people we collectively serve. So a little over 2 years ago, ACL launched the housing partnership, the partnership between HUD and HHS to create the Housing and Services Resource Center. And this was really a critical step needed before we could move to the kind of partnership with states we hear today. As the Housing and Services Resources Center partnership grew, we were thrilled this year to launch the Housing and Services Partnership Accelerator, or as we call it, HSPA. And we are already seeing firsthand, state by state, the breaking down of long-standing silos. We're identifying all the ways we can leverage all of our different resources and our networks. And there are so many dedicated people and organizations we can collectively bring to the table to solve these issues. And I'm so excited as I'm seeing people put their names in the chat. We have people from all these agencies, state agencies, healthcare, aging and disability network, housing agencies, organizations fighting homelessness, and other social services networks. Success is about building bridges and forming effective collaborations among federal government, states, counties, cities, and housing, homelessness, healthcare, disability, and aging organizations in every community. And I want to particularly highlight the value and importance of bringing in ACL's disability and aging networks who bring real expertise and support for people with disabilities and older adults as we work together to accelerate our partnerships. I've mentioned before that I love the word accelerator because that is what we are doing, truly stepping on the accelerator. We are taking these lessons learned in each state and showing the country that we can effectively address the housing and services needs for the community of people that we collectively serve, people who are experiencing or at risk of homelessness. And again, excited to hear from 3 HSPA states today, Arizona, District of Columbia, and Hawaii, who will share news about their partnerships, lessons learned, and best practices. As I said, we have a lot of federal agencies and departments who've been working with us to address these issues. And so I want to give a quick shout out to the alphabet soup of our partners, CMS and SAMHSA and HRSA and HSPA and many other departments. Our success truly depends on all state and community leaders who are here today. We can help coordinate, we can help with funding, we can help bring in experts to provide technical assistance, but it's truly your commitment and your hard work that will move the needle. Each of you, together with us, are paving a way forward for how to better align housing and services. So I'm really glad you're here. I'm glad you're committed to taking things to the next level. And with that, I want to turn it over to my friend and colleague, Richard Cho, to share a little more about our partnerships and the progress we're making. Richard, the floor is yours.
Thank you so much, Allison. And I want to give you a special shout out for your incredible leadership at the Administration for Community Living. You've done so much, Allison, and I think the nation is better for it. And I know older adults and people with disabilities are better for it in our nation. So thank you so much for your service and leadership over the years. As Allison mentioned, the joint partnership between HUD and HHS to help communities link the various programs that HUD provides to provide housing assistance with the various resources and opportunities that are provided through HHS to fund supportive services, home and community-based services, and other wraparound supports for people who are experiencing a risk of homelessness. That is the work we've been doing since day one. HUD, under the Biden-Harris administration, has been responding to the crisis of homelessness with the urgency that that crisis requires. And we are very proud over the last 3.5 years to have provided communities with more resources to address and prevent homelessness than any other prior administration in history. We provided significant housing vouchers, including the first ever voucher program, emergency housing vouchers that were specifically designed to address homelessness. We also provided the first ever package of grants and housing vouchers to address the crisis of unsheltered homelessness, as well as homelessness in rural communities, over $500 million that went to 62 communities to address unsheltered homelessness and encampments and rural homelessness. We've also issued more housing vouchers in the last 3.5 years than has been issued in over 20 years. And on top of that, significant resources to expand the supply of housing, including permanent supportive housing. We provided $5 billion through the Home American Rescue Plan program that can be used to help create permanent supportive housing and other low-income housing for people experiencing a risk of homelessness, as well as to purchase and convert hotels and motels into non-congregate shelters. And just this year, we made available another $175 million specifically to expand the supply of permanent supportive housing, as well as made available $3.5 billion in annual homeless assistance through the Continuum of Care program. Now, all of that is primarily about funding rental assistance, as well as capital to help build housing. But as Allison mentioned, we know that what it takes to solve homelessness for people with chronic health conditions and people with disabilities is a combination of housing and services. Now, HUD plays some role in funding those supportive services, and a significant part of our homelessness continuum of care grants do fund supportive services. But for the most part, we really rely on communities to leverage other resources to pay for those wraparound supports, those housing-related services that can help people not only find and move into homes, but also retain their tenancy. Around the same time as we were providing these resources, and I know Dr. Jessica Lee from CMS will be speaking shortly, CMS put out guidance that helped clarify the ways that Medicaid can actually cover housing-related services and the various Medicaid authorities that cover services like pre-tenancy supports and housing navigation services, services like tenancy sustaining services and individualized case management, as well as services that help people transition and move into housing who are moving from homelessness or other institutional settings. And so the building blocks have been provided by both HUD and HHS to provide housing and services. But those building blocks are not always easy to fit together. It's a little bit like Legos and Tinker Toys and Lincoln Logs. These are all building blocks, but they weren't exactly meant to fit together. And so while we were hearing of many states taking advantage of these flexibilities under their Medicaid programs to cover housing-related services, we also knew that there were challenges at the local level of how to coordinate those Medicaid services, the service provided through the Older Americans Act, services that are available to states with the various programs that HUD provides so that communities can pair housing and services. That is what led to the Housing and Services Resource Center that Allison mentioned, the joint TA center that HUD and HHS operate. But in addition, we wanted to be able to work closely with that first cohort of states who were some of the first in the nation to take advantage of the Medicaid flexibilities to cover housing-related services, to ensure that they not only were not trying to implement this on their own, they had a direct channel of communication to the federal government and to both HUD and HHS, but also to ensure that they had the opportunity to work closely with one another. Now, many of you heard the phrase, if you've seen one Medicaid program, you've seen one Medicaid program, and that is true. States vary significantly in how their Medicaid programs work. But we also know that there's many commonalities in how to coordinate housing-related services with housing assistance programs, and that there were opportunities for states to be able to at least compare notes, if not learn from one another, as they were working to implement these Medicaid-funded housing services and coordinate those with housing vouchers and with homelessness assistance grants. And that's what led to the Housing and Services Partnership Accelerator, one of the efforts that I'm most proud of that HUD and HHS have launched together. The states that are participating and have participated in this have been working closely with federally funded technical assistance providers to receive individualized coaching, as well as participating in learning tracks where they've been able to actually work with one another. And I think beyond technical assistance, this initiative has really been about building a new movement and creating a new set of leaders across the country who are able to think creatively about how to blend and braid resources, both federal and at the state level, to create housing and services. I think we are just at the beginning of this new wave of innovation and policy development in the ability to fully leverage Medicaid and HUD programs to create housing plus services. And I know that we will make significant progress in addressing our nation's homelessness crisis, as well as supporting community living for people with disabilities as the progress in these states continues. So I'm very excited to hear from 3 of the states that have been participating. And then last thing I'll just say is that this initiative has been such a success that members of Congress have also put their support behind this. In the fiscal year 24 budget that was passed, funds were specifically set aside in HUD's budget to continue the Housing and Services Partnership Accelerator. So I'm pleased to announce today that we will be launching a second round of the Housing and Services Partnership Accelerator later this year. So in the coming months, you should expect to see more information about that second round of the Housing and Services Partnership Accelerator, because we know there are many states out there that applied, but were not able to be selected for this first cohort. And second, we know there are many more states that have received approvals from CMS to cover housing-related services as a health-related social need under their Medicaid programs since we launched the accelerator. And second, that many states are submitting requests to be able to amend or pursue an 1115 demonstration to cover housing-related services under the Medicaid program. So again, we hope to build a greater cohort of states that are working to tackle these challenges and that are really proving to be successes in linking housing and services. So with that, I will turn this over to my good friend and colleague, Dr. Jessica Lee, Acting Chief Medical Officer at CMCS.
Thank you so much, Richard and Allison. It's really been such a privilege to partner with our federal colleagues and also to work with the state partners that have been a part of this collaborative. We at CMS have been working with our state partners to create groundbreaking opportunities in Medicaid and CHIP to meet the needs of the whole person by covering clinically appropriate and evidence-based services and supports that address health-related social needs, such as housing instability and food insecurity. This innovation supports the core goal of connecting people with evidence-based interventions and partnering with housing and social service agencies to improve access for individuals with specific clinical conditions. We recognize, though, that the federal policy is only the first step, and it's only through successful implementation that our beneficiaries can actually realize the promise of these policies. That requires new collaborations at every level: federal, state, county, community, provider, and beneficiary. The accelerator has given us the opportunity to learn together how to implement these innovations, how to create new partnerships. And I'm so excited to learn today from the states featured and share the best practices that have been developed over the last year. I'm going to be very brief so that we can really get into the states, but just so grateful for the partnership that has existed and made this accelerator possible and the opportunities to improve for the future. Thank you.
Thank you very much, Allison, Richard, and Jessica. Next slide, please. As you heard from Allison, Richard, and Jessica, the goal of the HSPA is to support states and communities to accelerate the development and implementation of innovative state strategies to provide housing-related activities and supports to persons with disabilities and/or older adults who are at risk of or experiencing homelessness. And the reason is because we know that the coordination of housing assistance with wraparound and supportive services is a proven cost-effective approach to assist older adults and people with disabilities and individuals with chronic and complex health conditions transition from homelessness, exit or avoid institutional settings, and live in the community. Next slide, please. To be eligible to participate in the Housing and Services Partnership Accelerator, states had to have an approved 1115 demonstration or a 1915I state planned amendment that includes coverage of housing-related supports and services. Through a competitive process, 8 states and DC were selected to participate in the year-long accelerator. State accelerator teams are multi-sectoral to bring together aging, disability, housing and homelessness, health, including behavioral health and social care, and again, Medicaid. And here you'll see a map in which all of the participating accelerator states are highlighted in blue, and the rest of the map is grayed out. Next slide, please. And here are some of the types of housing-related services and supports that states are covering through 1115 demonstrations and their 1959 state plan amendments for Medicaid-eligible persons. With our TA, we're helping states find solutions to the challenges of how to operationalize these supports. Next slide, please. And here you'll see an illustration, and this illustration will give you a sense of, next slide, please. There we go. A sense of how housing, health, and social care partnerships can support an older adult, a person with disability exit homelessness. The top arrows show the funding streams that can be braided together to provide a seamless set of services and supports for individuals in the community. Green is the Medicaid or managed care funding for not only healthcare, but also pre-tenancy and tenancy sustaining services, as well as in-home services. In red, we have grants from ACL, SAMHSA, and other sources that community providers use to support outreach to people who are unhoused and to provide an array of supplemental services and home and community-based services. And blue is housing voucher or rental assistance from PHA, homeless continuum of care, or other source. Ideally, all 3 types of supports, housing, health, and social care, are available and coordinated as a journey from homelessness to housing stability. The lines are dashed because the mix of supportive services should be responsive to individuals' preferences and needs in a housing-first approach, and the mix of available supports in a community varies. This type of model succeeds when all sectors closely collaborate, so the period of homelessness is brief and one time. Next slide, please. In January, we held a kickoff webinar with all states selected to participate so they could meet their peer states within the accelerator, TA providers, and federal agency partners, and discuss their goals and TA needs for the accelerator. An individualized TA needs assessment was conducted with each state in order to tailor the individualized TA and peer learning opportunities of the accelerator. One-on-one state coaching was delivered and is delivered to each of the states. So every state was assigned a 2-person coaching team with a housing and Medicaid services subject matter expert. Coaches meet regularly with cross-agency state teams to offer subject matter expert and one-on-one implementation support focused on individual state goals, challenges, and opportunities identified during the needs assessment. Coaching teams can also draw on the expertise of federal partners, peer states, and other subject matter experts as needed. There have been peer-to-peer learning opportunities. So monthly, there are interactive group learning webinars that are also held featuring topics of common need identified through state TA needs assessments. States also had the opportunity to attend a 2-day in-person meeting in the DC area where they participated in a topical learning session, roundtable discussions, along with plenary sessions that provided opportunities for federal partner dialogue and support. We were able to record the plenary sessions for that in-person convening, and those are available on the Housing and Services Resource Center website. And finally, states will have the opportunity to participate in a final learning webinar at the end of the year-long accelerator to share their lessons learned and plans to sustain their work on an ongoing basis. Next slide, please. Here are some of examples of the types of priority goals and common TA needs the state's focused on through the Housing and Services Partnership Accelerator: strengthening and expanding state and local partnerships, braiding and aligning housing and services resources, preparing to launch and integrate new 1115 health-related social needs housing supports, building provider capacity, working with managed care, developing payment and reimbursement models, and accessing and integrating data to support the alignment of housing services, eligibility, and improve care coordination. And next slide, please. Now we just want to do a couple quick audience polls to first learn whether your state is currently covering or planning to cover housing-related services and supports under Medicaid. So your options are that you're currently covering under your 1915I state plan authority, currently covering it under an 1115 demonstration, currently covering under another Medicaid authority, planning to cover under a 1915I state plan authority, planning to cover under an 1115, and planning to cover under a different Medicaid authority. Or you don't know or you're unsure. So we'll just give it a couple seconds for folks to be able to respond. And next slide, let's share the poll results. So we have a pretty good distribution with a lot of folks who don't know or are unsure. So my colleagues will drop some information into the chat where you can go and look up what might be covered under your state Medicaid plan. And next question, next slide, please. So how are you engaged in your state's planning and or implementation related to Medicaid housing related services and supports? Very engaged, somewhat engaged, not at all engaged, not applicable, or other? Please explain in the chat. And we'll give you a couple seconds to respond. And we'll go to the poll results, please. Okay, so we again have a mix of folks here from at least almost half of the folks who are engaged or somewhat engaged. Thank you. Next slide. And next slide, please. And now we're really excited to introduce our speakers today from the 3 participating HSPA states who will share about their progress to date in the accelerator, lessons learned, and best practices. First, we'll hear from Elizabeth DaCosta, Director of Housing for the Arizona Healthcare Cost Containment System. Then we'll hear from Elizabeth Garrison, Senior Project Manager for Healthcare Reform and Innovation at the DC Department of Healthcare Finance. And last, but certainly not least, we'll hear from Judy Moore Peterson, who is the MedQuest Administrator for the state of Hawaii's Department of Human Services. And with that, I'm going to turn it over to our first state presenter, Elizabeth DaCosta.
Thank you so much. So yes, I'm the Director of Housing with our Arizona Healthcare Cost Containment System. It's the state Medicaid agency in Arizona. We can go ahead and go next slide. I see a lot of really great questions coming in the chat, so very excited to share with you all today. We can go ahead and go next slide again. Really important, though, I think that we level set really the Arizona landscape as it pertains to housing, because we are not new to the housing space within the state Medicaid agency. Really, we had a class action lawsuit. It was called Arnold v. Sarn, where we were found to not have enough comprehensive community mental health services available to members who had serious mental illness within the state. And so through an exit stipulation, we have requirements that we build out permanent supportive housing services that follow SAMHSA's evidence-based practice for permanent supportive housing as an exit stipulation, and that has been in place for years. from my perspective, you don't ever want a class action suit, of course, to be your reason why you move forward with something, but you know, it has been a framework in place that has allowed us to continue to have these resources dedicated towards permanent supportive housing that at the state Medicaid agency, we've been able to manage without having concerns with it being removed for political reasons that have allowed us to be very innovative in our program design. So through those exit stipulations and a lot of work with advocates, the state Medicaid agency gets $29 million in a general fund appropriation to be able to cover rental assistance across the state for eligible members. And we designed that to be a permanent supportive housing model. We'll go ahead and go next slide. I saw some comments in the chat about, you know, how those rental assistance dollars are administered. And so really unique for Arizona too is that we used to give those dollars over to our regional behavioral health authorities, which are the managed care organizations in the state of Arizona that are responsible for serving members with serious mental illness. And so for years, they did a really good job of administering those dollars and making sure that members have access to those rental assistance dollars to be able to lease up in communities. And what we found though was that we really wanted to move in the direction of having a contractor who has, you know, who has a lot of expertise and skill in actually managing like public housing authority type vouchers. So we did a request for proposal back in 2020 to seek one statewide housing administrator, and then we awarded that back in October of 2021. And so our current contractor is Arizona Behavioral Health Corporation. You can see their reference to their organization on the left. And then they also do a subcontract with an organization called Home Inc. And so what we've really done through that model is we've allowed the experts in the behavioral health space, our managed care organizations, to go focus and serve in that capacity while building out the housing authority type expertise within our statewide housing administrator contract. So Home, you can see on the right, they do the member briefings. They make sure that leases follow landlord tenant law. They also do the HQS inspections on the unit. So really all of that evidence-based, not evidence, but best practice stuff that's built out in those public housing authorities, they've replicated in the work that Home does. But we decided to have a hybrid model too, though, because we wanted to make sure that vulnerable members with significant mental health issues or concerns would be able to have an advocate that is helping to make sure that if there's a lease up due, recertification due, we've got a lot of infrastructure to perform the right level of outreach to be able to connect with the member to get them in so that they can continue to receive those rental assistance benefits. We can go ahead and go next slide. And then as a part of that program, as it stands today, so we've got that rental assistance component paying for the unit, but then also we've got the supportive service component that is still the responsibility of our managed care organizations. So through Access Medicaid approvals with CMS, we have covered services under a rehabilitation package where providers who are onboarded as registered Medicaid providers that follow state licensure requirements, they can, you know, get out into the community and help an eligible member develop an assessment and then an integrated care plan, identify which of the covered services the member is in need of, but then use those covered services to be able to actually get out in the community and provide supportive services related to housing to members, and then go back and submit those covered services as billing codes to Medicaid for reimbursement. So on the left-hand side, we just show what those covered services are. And in Arizona, they include peer support services. And then in the middle, we show, and the last one, we show how these services are used to help members attain and then also retain housing. We can go ahead and go next slide. So of course, outcomes are really important, right? So we had that class action suit with the exit stipulation that led us here, but it's outcomes that we get for our members that help drive us into innovative ideas for the future. So in 2020, that program served 2,400 access members. And you can see on the slide, we had a 31% reduction in ED visits for those members, emergency department visits for those members, a 44% decrease in them needing to go through inpatient admissions, a 92% reduction in behavioral health residential facilities, and then around a $5,500 cost per member per month savings. When we were paying for members to be to live in housing, we saw that cost savings. So we can go ahead and go next slide. So that led us to our 1115 waiver request with CMS. We started working on negotiating this, back in 2020, 2021, and received approval from CMS to be able to cover health-related social needs interventions as a Medicaid benefit in October of 2022. And really important, though, what that approval means is they give us an approval notice to our waiver demonstration, but then also a series of standard terms and conditions that we must then develop protocols, implementation plans, policies, rates, right? All of the actual operational stuff needs to get communicated back to CMS and approved before we can actually implement the service. So we received the approval in 2022, and we are getting ready to go live now here, October 1 of 2024, right around the corner. So you can kind of get a sense of the work and time it takes to really be able to operationalize even post-approval. But these are the services we're going to be able to cover as a Medicaid entitlement benefit for eligible members. Outreach education services was approved under our infrastructure dollars in Arizona, so it's still going to come in more as like an administrative expense. But very exciting, probably for the housers in this webinar right now, is that we're approved to pay for transitional housing up to 6 months as a Medicaid benefit. So really bringing together that housing and healthcare model through actually allowing the Medicaid system to have the funds to cover the intervention for housing. We've broken that down into 2 types of interventions in Arizona. So the first is an enhanced shelter. We know, as through data has told us in just use case stories and member stories from our Access Housing program, that even when a member gets their voucher, there still is a long time it takes for them to find a unit, a landlord that's wanting to work with them, given their background, pass an HQS inspection, all that stuff that I'm sure a lot of you are very familiar with. And we lose a lot of very vulnerable members through that process if they're living in unsheltered situations. So that's why we're building out that enhanced shelter model. So eligible members for this benefit will be able to have a safe, stable location in which they can reside while they're going through the housing process. And then the other thing we've built out is the ability to actually pay for up to 6 months of short-term rental assistance for a member to actually take those dollars and go lease up in an apartment in the community. Really important, I think, for the 1115 waiver approval for Arizona, and why we wanted to participate in the Housing Service Partnership Accelerator Program so eagerly, is because we obviously have leases that are 12 months. A member needs more than 6 months of short-term rental assistance to truly be able to stabilize in housing. So we do a ton of work on partnerships with our public housing authorities that I'm going to get to in future slides. So the other things we were approved for is just incidentals in the housing space. So the ability to be able to pay for a security deposit to help a member move into their apartment, or utility arrears so that they can turn their utilities on, home accessibility modifications as well. I think one's really important, though, for today, and what I've seen in the comments and questions coming in so far is those supportive services. So as I mentioned on that slide before, in Arizona, folks can bill covered services to be able to provide supportive services to members. But right now, that is through our existing infrastructure of full behavioral health assessments, integrated care plan development, and then most often 15-minute increment billing. And so what we've seen from our results is that it's very challenging to get to the SAMHSA permanent supportive housing evidence-based model with the rate infrastructure we have today. So what we've done through the H2O 1115 waiver approval is really try to work out pre-tenancy, tenancy sustaining services that reduce administrative burden, and we're going to be funding them at a per member per month rate. So we can try to demonstrate how impactful our supportive services can be when our rate methodology matches the funding needed for a SAMHSA evidence-based practice for permanent supportive housing. We can go ahead and go next slide. So really important, I talked about those standard terms and conditions. So I did hyperlink our standard terms and conditions here so folks can see, but you get the approval, and then CMS said as a part of the standard term and condition 36, the state must determine clinical and social risk criteria to determine eligibility for the program. So that's really the framework CMS gives, and then it's up to the states to really determine, okay, well, what clinical and social risk factors should we implement within Arizona that are going to help integrate this resource within our system, that will help serve very acute and vulnerable populations. So we took that standard term and condition and we determined that for initial rollout, October 1 of 24, this is the criteria for members to meet H2O eligibility to be able to access those services I shared on the slide prior. So you can see members must currently be experiencing homelessness. They must also have an SMI designation within the state of Arizona. And in addition to that, have a chronic health condition that was found to be a driver of healthcare costs, or be SMI and also have justice involvement or been recently released in the last 90 days. So I know it's, we really kind of honed in on a specific population, but there's a lot of things that come with waiver demonstrations that require you to have to really, focus in to be able to remain budget neutral on a specific population, because when you determine that population to be eligible for the Medicaid entitlement benefit, the state must ensure that member has access to that entitlement, whether or not there's funding or not, right? So that's kind of like the context for the STC to our population that we'll go live with. We can go ahead and go next slide. So obviously a lot to implement, even with an approval in 2021, trying to figure all of the stuff out to be able to make this a benefit, by 24. So when we saw that the Housing Service Partnership Accelerator Program was an option, we immediately applied. And what I've done here is I've tried to show like all the focus areas from what we kind of call HSPA now, how it actually applied to Arizona. So when we talk about strengthening and expanding state-local partnerships, one of the most important things we needed to do for the outflow of members with our services was identify that long-term subsidy that members can transition to. So if we help move them into an apartment following all best practice standards of a public housing authority, how do we seamlessly transition them to a housing authority housing choice voucher or a HUD continuum of care program, permanent supportive housing voucher? That's really our model. So through this HSPA partnership, we've actually have now public housing authority roundtables that are scheduled, and I'll get into it a little bit. We found out within the Medicaid agency that there's an AHADA group, and it's the, I have to write it down because I'm not as familiar with the Arizona Housing Authority Directors Association. So an entire group of folks that are already the directors of our public housing authority. So we were able to go to that meeting that they have and present on H2O, trying to really work towards that standardization. We also looked at members who are potentially eligible for H2O and then found high density areas. So we can really try to focus in on particular areas for partnerships with public housing authorities. I'm going to flip over to the building provider capacity. When we talk to our community-based organizations about the ability to bill Medicaid to cover health-related social needs interventions, they were very nervous about it because they don't have the electronic health records or the organizational infrastructure to be able to maintain compliance. So what the state did is we moved towards a procurement for an H2O program administrator to administer the program for us, do the direct contracting with community-based organizations, help them become Medicaid registered providers, and then help them also submit invoices in the same way they are now. But then the H2O program administrator actually turns that invoice into a Medicaid claim. The next is developing payment reimbursement models. We really wanted to make sure that we were covering total cost of care. So through HSPA, we did a lot of work and actually contracted with Corporation for Supportive Housing. They met with permanent supportive housing providers across the state of Arizona, had them fill out their budget tool, and then provided that information back to the state to access. Our rates team used that provider information to inform our per member per month rate for the pre-tenancy tenancy services for H2O. And then we can go ahead and go next slide. I know I'm getting close to time. This just tries to give you a visual of that relationship. So I talked about on the right-hand side, everything that exists as it does today with the Access Housing Program, overseeing our statewide housing administrator, and then also our managed care organizations are in the green, but the H2O initiative, everything will be built out under blue, with our H2O program administrator having the direct relationship with all H2O providers across the state. We can go ahead and go next slide. So these are our challenges. You can see the road was very busy, but when we tried to identify which public housing authorities had housing vouchers that we could try to allocate towards our initiative, we found that a lot of them were under-resourced. When the fair market rents increased, in our state, they had to be competitive and get to those fair market rents. And so they started to overspend, but not show that they were fully leased up with vouchers. So I know that was a lot, but in essence, we had under-resourced public housing authorities within Arizona. We also had, we could get one public housing authority to agree to partnering with us, but we have members across the state who will be eligible for our 1115 waiver services. So we really needed to find a way that we do agreement to have a statewide standardization for the partnership. And then also, I'm going to skip down to the fourth bullet with the clinical and social risk factor guardrails that required the state Medicaid agency to really hone in on that eligible population, but it doesn't mirror, the eligible prioritization for our continuum of care programs. So, just a bit of a challenge there in trying to get to a shared prioritization across resources. We can go ahead and go next slide. And then here's our lessons learned. So yeah, we have really good contacts, and we know, like I mentioned, the AHATA work group, where we know exactly who we need to talk to get system level improvements in place for our partnerships. We understand the Public Housing Authority Housing Choice Voucher waitlist processes and how they differ slightly from the HUD continuum of care ones. Through the work with the ACL, we've identified who our AAA resources are and the priority populations in which they're designed to serve, and we've identified all of our contacts. We still have work to do in this space. Obviously, working towards implementation of H2O, things have been very busy, but we have recognized those AAA resources across the state and have goals for continuing to integrate services with the AAAs and the housing services that we do within the Medicaid agency. Like I said before, we've got the payment reimbursement models that we learned from. And then the last thing is this, what we've determined is most in need is this vital need for resource integration. And then we'll go next, it's the last slide, and it tries to wrap up our vision of the vital need for resource integration. So as the state Medicaid agency worked towards implementation, we met with community-based organizations, we met with our continuum of care leads, and we just continued to hear how they had been working on some really fantastic programs, but had some troubles with operationalizing it, especially around the concern for lack of supportive services. So one example is they had a lot of resources focused on developing move-on strategies. So how you can take a member from a continuum of care program who's been stabilized for years and help them transition to a public housing authority housing choice voucher. They had a lot of resources focused in on that. So what we decided is our goal is to really actually learn about everything everyone is doing in the housing continuum space, consider it kind of the highway to housing, and figure out, rather than on the left-hand side, the CMS 1115 waiver services in Arizona coming in as like another kind of siloed resource, actually figure out how we can use our resource to improve the on and off ramps for all of the resources across the state and partner with everyone. So you can see a lot of the details on the slide. Through the HSPA, we have our HUD regional office staff participating in our roundtable discussions with us at the state Medicaid agency. Our continuum of care is included because we're working together to really develop the templates for operationalizing how you move someone from short-term Medicaid assistance over to a housing choice voucher in a very seamless fashion. And with that, I'm going to go ahead and wrap it up. I think I went like maybe 2 minutes over, so thank you so much. I'm going to hand it over to Elizabeth from DC.
Hi, good afternoon. I'm pleased to be able to speak with you all today. My name is Elizabeth Garrison, and I am a senior project manager with DC's Department of Healthcare Finance, working on healthcare reform and innovation projects. Next slide. So I wanted to talk with you a little bit about the focuses of DC's HSPA work. We have been a state that has implemented a 1915 I-State Plan Amendment, so I'll speak with you a little bit about how that process works. We have approved both housing supportive services as well as housing navigation services, and we began billing Medicaid for those, rating those with an existing permanent supported housing program in 2022. I'll note that DC is a small geographic area, so we have a lot of regional and state alignment in terms of our systems, which I think is a little bit different than some other locations. We have one single continuum of care, and we also have a lot of alignment with our sister district government agencies who are responsible for coordinating and administering certain aspects of the benefit. And I'll say also that our providers are paid on a per member per month rate. and that we are intentionally pairing the services with the assigned voucher resource to try to enhance the likelihood that individuals will be able to receive and maintain permanent housing and be stabilized in the community. I'm trying to speak up. I saw a note that I may not be heard very well. Is that better?
Yes, thank you.
Great. Next slide. So I'll talk a little bit here about our matching process. This illustrates the process that is administered by our partners, the Department of Human Services, as well as the community partnership that works with DHS. And essentially this maps how individuals are linked to a voucher resource and then enrolled in the Medicaid benefit program for 1915I services. So we have some resources through street outreach, as well as other programs and shelter resources that will identify individuals and support completion of a VSPDAT or other assessment tool. And through this process, there is a central by name list that's used in order to determine the vulnerability level and need for housing. And individuals that meet the requirements of the 1915I benefit, meaning that they have to have a disabling condition as well as a history or risk of homelessness that meets the benefit criteria, would then be matched to the permanent supported housing program. Our partners, Department of Human Services, actually perform the intake assessment and the person-centered care plan task. So they meet with the individual, they walk through all of the factors that might be contributing to their need for homelessness. And they also then give education to the recipient about what the options are in terms of service providers. They match the individual to a service provider. There is a choice process by which the individual, can accept or request another placement. And then at that point, they are enrolled with the housing provider, and a prior authorization code is generated that maps to billing the 1915I placement. And I'll note here that individuals follow this process regardless of their source of health insurance. So this is the same process that's followed for both Medicaid beneficiaries as well as people who may be uninsured or insured in some other fashion. If folks meet the program eligibility, they may also, be leveraging other sources or resources such as like the DC Healthcare Alliance program or other resources for their health insurance, in which case DHS would pay local dollars for the same services to the same provider network. And there is also an add-on local dollars payment that is made available to the head of household in the event that it's a family that's receiving services to help address the need for a more comprehensive service planning approach that might mean a different set of resources and supports to ensure that they're addressing the barriers that might be impacting a family's need for stable housing. Next slide. This goes into a little bit more detail about our assessment process. For those of you that are familiar with the 1915I benefit, there are some substantial requirements around that benefit in terms of the conflict-free assessment. And so this just goes into a little bit of detail about how DC has determined the best process to meet those. We do, as the Medicaid entity, designate to DHS to perform the conflict-free assessment and to ensure that the appropriate enrollment is made to providers. And then on an annual basis, DHS reassesses the individual with both the functional assessment as well as ensuring that they're linked to an appropriate provider resource and works with them to make sure that they have the right service plan. Next slide. So I think that there's a lot of benefit to being a small town in the event of developing a benefit like this, especially when we're bringing new providers into the Medicaid program. I will say that it was a very collaborative, lengthy process in order to design the 1915I benefit, where there was a lot of partnership across district agencies, namely DHCF, where I work, as well as the Department of Human Services, our Interagency Council on Homelessness, and many provider entities really contributed to designing the benefit. There was a lot of work to look at how to standardize and to streamline processes across the network, because we had, multiple rounds of local dollars, permanent supported housing programs that had been funded previously. After we implemented the benefit, we had to go back and make some additional changes as a result of some of the provider feedback. So I'll talk a little bit about some of our lessons learned. We found that there was a lot of work that was necessary for scaling and training staff, particularly around, the coordination with vouchers, as well as the coordination with 1915I requirements, such as assessments and placement. So we found that the technical assistance resources that we provided were very helpful, both for billing as well as for understanding Medicaid, particularly for new providers. There were also a number of providers that were brand new to permanent supported housing that came on board right around the time that the Medicaid benefit was launched. So there was a lot of resources that were put out there to kind of help bring their capacity up and help ensure that they had capacity to bill and to meet the program requirements. They also did a lot of support with individual provider enrollment to help navigate the Medicaid provider enrollment criteria and credentialing and all of those fun processes. We found that there were also some changes that were needed to be able to be responsive to concerns that the provider community had around staffing. And there were a lot of impacts that were still being felt in the provider network, I believe, as a result of COVID and as a result of scaling that had happened with some of the pandemic federal resources as more vouchers were made available. And there were challenges around hiring and retaining both case managers and supervisors. There was also a concerted effort to educate both the Medicaid program and Department of Human Services on the need to recognize the role of individuals with lived experience and to look really at how the levels of case management, education requirements might be impacting filling those roles. So we were able to work with CMS to make some modifications to the staffing requirements, and those were very positively received and I think have resulted in some improvements in terms of providers' ability to deliver care and to keep those programs fully staffed. We also found that there needed to be additional work to support providers around the authorization process. And partly this was related to all of the work that DHS needed to do to scale up to be able to not only manage the conflict-free assessments, but also the generation of the prior auth numbers and to make sure that there was coordination for billing across both district agencies. So we've made some changes to streamline that, and we're continuing to look at opportunities through data integration about how those processes can be further improved. And I'll just note that we've been able to also really leverage these additional the additional federal match that we are now receiving as a result of the Medicaid benefit, and that's enabled DHS to provide more services and to be able to look at opportunities to expand and place more individuals with vouchers that were available. Next slide. So through our HSPA project, we've been really fortunate to partner across the aisle with a lot of really knowledgeable individuals. They've done a tremendous job of helping to educate me and the rest of the Medicaid program, and we're looking forward to continuing to work with them on many of our projects, which will be long range. We've focused on really trying to understand how programs work. We are looking at opportunities to strengthen our continuum of resources, not only by strengthening the 1915I benefit, but also through a health-related social needs 1115 waiver, which we have been able to submit the application for that those new housing benefits in May of this year. So we're looking forward to implementing services. I believe those are anticipated to begin in January of 2026. And we're looking at how specifically some of the 1115 care coordination resources, as well as 6-month housing rental assistance and other supports will help to enhance care gaps that we have throughout our system. So to that end, we've done some mapping with our partners, and those partners have included, managed care providers, other district agencies, including Interagency Council on Homelessness, Department of Human Services, our Department of Aging and Community Living, as well as, DC Department of Health, Department of Behavioral Health, and other partners. We've had a really great team. Next slide. And then where we're focusing now, we're really looking at how we can continue to work on data integration. DC is fortunate that we've done a tremendous amount of work to build out infrastructure for data sharing, leveraging DC's Health Information Exchange. And so we're looking at how we can now start to integrate more social needs data into that system. HSPA has allowed us to identify some potential pathways, but all of this is really intended to make sure that we have the right systems in place when our new 1115 benefits come live, as well as to figure out how we can potentially leverage Medicaid data and other sources to help assist the voucher placement process or CAP process through perhaps better access to information on health challenges and medical eligibility for prioritization and other factors. We're also looking at how we might be able to streamline some of our provider data entry requirements through that. And we have made some partnerships with our DC Health Department to be able to bring in a single sign-on feature for referral and dedicated closed loop referrals between social needs providers and medical providers. And we may also be able to use a consent-based sharing feature that was developed for protected substance use information data. We're looking at opportunities to leverage that to also share with between HIPAA and community-based organizations. We're continuing to look at opportunities for reimbursement for some of our new benefits, as well as really looking at how to create dedicated referral pathways from care transitions and from hospitals and other providers to really make sure that we're routing people to appropriate permanent housing resources. So I'll stop there. I know we are running a little bit behind schedule, but I want to now turn things over to Judy Moore-Peterson from Hawaii to present about Hawaii.
Thank you so much. I really appreciate I really appreciate my colleagues going before me. I'm Judy Moore-Peterson. I'm the MedQuest administrator. That's the title for the Medicaid director. We would have our subject matter experts leading this panel, but they happen to be on a site visit today with other CMS officials who are visiting our state to review one of our other programs. So next slide, please. So I'm doing my best to fill in. So this is a little bit about our Medicaid program. And what I really wanted to emphasize with this is the fact that our Medicaid program is really focusing on this concept of embracing wellness from a whole person perspective. And in order to do that, we need to look at various different kind of health-related social needs, including housing. And in our state, we have one of the most expensive and competitive housing markets, really in the world, but for sure in the country. And that has actually led to a severe issue and for our people to have access to housing. And so we have a high rate of houselessness in our state, particularly for those who are suffering from serious mental illness or have substance use disorder challenges. It is a major focus for our governor in particular, and he's been very much focused on this and trying to increase the affordability or getting additional affordable housing in our state. But in that process, he also he's called on the Medicaid agencies, actually called on all of us to be working together to try to find innovative ways in which to help address this serious issue in our state. And so he tapped the Medicaid program to make sure that we would do everything that we could possibly do. So, and this particular TA came at a really critical point for us in helping us identify partners and creative partnerships that we could have and that we could develop further in order to help meet this continuous focus on addressing homelessness in our state, particularly for individuals who are facing behavioral health challenges. Next slide. So we actually currently have, in our current 1115 authority, we have something called Community Integration Services, which provides the offering of tenancy supportive services, wraparound services. So includes outreach, pre-tenancy supports, tenancy sustaining supports, some transitional case management, and a very limited rental assistance. In other words, it's just first month's rent. We were unable to, due to COVID, we were unable to implement that, but the first months, but we have a pending 1115 renewal that expands the scope of our current community integration services, which we are now calling Community Integration Services Plus, in which we are similar to Arizona. We're seeking to get additional transitional rental assistance up to 6 months, inclusion of utility payments, again, and actually also including back rent and back utility payments. We're also looking at recuperative care, short-term post-hospitalization that we put under the umbrella of medical respite services. Those are particularly critical, those latter two, for if we're looking at the behavioral health continuum and the crisis continuum, having access to that recuperative care focused on individuals with serious mental illness or substance use disorder or serious substance use disorders has been quite key. One of the things that we did learn as we were implementing our current program is the challenges of implementing even the tenancy supportive services. We struggled at starting off with in identifying and working with homeless service providers who were already engaged in this particular space, but they weren't billing. Obviously, they weren't billing Medicaid for those services. So we had a small number, and then working through what the workflows would look like. It took a lot of effort and work. I don't have the details, but you can find that information on our website. We have long memos and describing the processes and the workflows that we're using. We had a lack of data sharing, as was noted earlier. Many of the providers, they struggled with becoming a Medicaid provider. We're a managed care state, so then they had to also get contracted with the managed care plans, and that was a struggle. And then the other learning that we had at the very beginning for challenges, which was a huge effort, is because this was an 1115 waiver, you have to have an evaluation of the various different efforts that you're doing. And so we thought, oh, hey, let's just include in this medical claim, we'll just add some modifiers and some different billing things to be able to capture each part of the information that we need. And then we'll just have the healthcare provider or the homeless service providers, they'll just fill in this claim and with all the right billing codes and modifiers and for everything that they're doing. And then we'll be able to use that information in our evaluation. And that turned out to be a dramatic mistake. So, because the homeless service providers, they essentially came to us and they said, we don't really want to talk to you anymore or deal with you anymore. You have made this so complicated and so challenging. We're spending more time with doing this paperwork than we are in actually providing the services. So we had to do a complete reset. We spent a lot of time listening and going out and working with the providers to really listen, deeply listen to, okay, what is it that you need? How can we break down these barriers? And so we came up with a completely different way of allowing the providers to bill for the services. We came up with a different workflow. We worked with the managed care plans. We did a lot of training, et cetera, on this particular point. So, yeah, so it was a lot of work, but that actually also illustrated for us the importance of working with the community and working with the providers as we're getting ready to roll out those, or as we're in the process of hopefully getting these expanded services. And so again, the HSPA partnership accelerator was really key because it put us again in contact with this broader group of individuals who we know that we're going to need to work with and hopefully avoid those kind of mistakes that we made in the beginning. But I'm sure as we're rolling it through, we'll make new mistakes. But that's, part of the goal here is if you have strong partnerships, then you're able to work through whatever barriers it is that you're facing. Next slide, please. So as always, so I'm just going to focus on this relatively quickly. I know that we're short on time, but as my other colleagues pointed out, one of the key factors for us in a benefit is actually reintroducing us to the housing side of this work. We had some connections with the homeless service providers, but now we were reintroduced to the continuum care providers and the folks who deal with the housing, the actual building, the rental assistance, the HUD vouchers, et cetera, because we're not really dealing with them very much. So that's a laundry list of folks that we're working with there below. And one of the reasons that is actually also so key, and you heard it through both my colleagues from Arizona and Washington, D.C., is that without those relationships and really meeting and talking and getting together, you can't have trust. And then you're not able to move forward with these innovations if you don't have those relationships and you don't have that trust in working together. Really, change moves at the speed of trust, and trust is built on relationships. Next slide, please. So some of the things that we're doing, which is very similar to what you heard from others, is we are also getting a mapping of the housing resources, and and what that means for us is, as you would have heard, there's different priorities, there's different requirements for each of these different funding sources and each of these different groups, including with Medicaid. And so many times we're left, we know our Medicaid speak, but we don't know what those other entities mean, what they do, what their priorities are, how to how to engage. And so this is we're trying to map out what those housing resources are, what the criteria is, how one can access them, who has them, et cetera. So that's actually a really, really key resource for us. We're still in the process of mapping all that out, but we're excited about that beginning. We're identifying the housing pathways, because as was noted, we don't 6 months is a limited time period, and we want to make sure that there's a continuum. And so that means really intensive workflow and discussions. Being island state, it's each of those varies by each island and each county. And so that's new partnerships, different partnerships that we have to work on, different providers who are in each location. We're actually exploring options to expand our housing opportunities by looking at the Section 811 project rental assistance funds and expanding housing availability, which we're excited about. So we're very excited to learn from our colleagues in the other states. Even today, I was learning as Arizona and Washington, D.C. were presenting. So we're super excited about that opportunity. And we're actually also happy to share everything that we're learning and going through. And it's good to hear. Sometimes it's good to hear. It's like, oh, you're struggling with that too. Good. I'm glad that we're not alone in that, in dealing with that. So very much appreciate this as an opportunity. We're very grateful that we were selected in this first cohort. We're already learning a lot. And we're excited about working with CMS then in getting our own waiver approved for these expanded services and the rental assistance, et cetera, and working through the operational protocols. And we're glad that we have other states who are leading the way. So with that, I will turn it back to Ryan.
Thanks so much, everyone. All of these presentations were excellent, and the learnings that were communicated were incredible. And we have got a lot of questions and excitement in the chat. One kind of common theme that we've heard from many of the participants today is an eagerness to really track and follow the progress of each of your state teams, and also understanding how might they be able to get connected into the great work that you're doing within your state. Liz, Elizabeth, Judy, do you want to kind of share what's the best way that folks can track your progress and how might they be able to participate?
I can start off, and I did. I think this came up as a question in the Q&A, so I did put a link in there. But looks like I'm frozen. Thanks. Can you hear me?
Yes, we can hear you.
Okay, so I will put the link in the chat. But Access has a series of community presentations that we do. It's our standard structure for making sure we're pushing out information as much as possible to all of our community partners. So I'm going to put that link in there. Again, as I mentioned, you can go on there and see all of the upcoming community presentations we have. Each of them will provide details if we are presenting on H2O or not. Another thing is, by all means, feel free to reach out to me if you have any trouble with connecting and figuring out additional information around our program.
I see that the information, the best way to connect with us is through our, you can find the information on our website. I did see in the Q&A that someone has kindly put in a link to both our waiver request as well as to where we have the community integration services. We're actually also happy to share individuals. If someone wants to contact through this webinar, they can get contacted to us, and then we're happy to put you in direct contact with the subject matter experts who unfortunately couldn't do the presentation today, and I'm doing my best to fill in.
All right, so we'd be happy to connect with any states that are interested in learning more about our strategies. We also have information posted both on the Department of Healthcare Finance and on the Department of Human Services website. about our 1915 I benefit. With regards to the 1115 health-related social needs application, we have been sharing information through our public meeting structure, through our Medicaid advisory committee, as well as through our Interagency Council on Homelessness public meetings. So feel free to reach out, and the TA partners can connect us with you if you'd like to learn more.
Thank you all so much. So we do have a question related to, is anyone using resources to provide retention for services for older adults, disabled persons who already have rental assistance vouchers or an apartment, meaning they are not currently homeless, but could potentially become homeless if they cannot meet the subsidy and tenancy requirements necessary to stay stably housed?
We do we have it through our home and community-based services, and individuals who are at risk. That includes at risk of institutionalization. We do include home modifications to help individuals stay in their home or stay in their location, including for those who are renting. So that is covered in the equivalent of the 1915C program. I hate to do the the numbers thing, but that's usually where you find services for home and community-based services in Medicaid programs.
So DC's Housing Supportive Services program has two phases, both a navigation phase and a stabilization phase. So for individuals that are in that program, they can continue to receive services as long as they continue to have a need and want to continue working with the community provider. And those services really focus on any barriers or issues that might interfere with them sustaining their housing. Like Hawaii, we also have other services that are available for folks in our home and community-based services and other waiver programs, such as home modifications and housing transition supports. So those are through our elderly and persons with disabilities waiver, as well as other programs.
Great. Go ahead, Liz.
The state Medicaid agency also has our home and community-based services. So I just wanted to touch in on that too. And then for our 1115 waiver approval, though, for our HRSN demonstration, we are focusing on individuals who are currently experiencing homelessness.
Great, thank you. So have any states experienced major delays in getting paid or reimbursed from Medicaid for these services?
Providers may experience delays, but that's usually just, from the managed care plan, et cetera. So they may experience delays, but the Medicaid program itself, that's not how we're funded. We get regular allocations from the federal government to help fund our program that also is funded with a match from the state funds. Sorry, Medicaid funding can be complicated. I was trying to simplify it.
So for DC, we are administering the Housing Supportive Services as a fee-for-service program, which means that providers submit claims to DC Medicaid and we pay those out on a timely basis. I will say that during some of our implementation period, we did identify some areas where we needed to make improvements to the prior auth process. And a lot of that was related to having a very small team at DHS and then needing additional capacity to be able to manage authorizations and make sure that they were making adjustments when people moved from navigation to being in permanent housing, which required a prior auth code change. So I think that we have largely addressed those and are able to pay in a timely manner.
And then for Arizona, we're going to go live October 1 of 2024, but our services will also go through our fee-for-service system, and they will also need to go through our H2O program administrator for some of that program integrity work that we're doing. So we've anticipated about a 3 to 4 week turnaround on reimbursement for claims to providers.
Thank you. So can you describe some of the benefit and challenges of pursuing tenancy sustaining services through 1915 I's versus 1115, especially when it comes to working with housing partners?
So oh, sorry.
You go first.
Okay, I'm happy to start. I will say that we have found that the 1915 I program has really worked to provide a pathway to Medicaid reimbursement for permanent housing resources for our population that was in need of those. What we are experiencing though is we're beginning to realize that there's greater breadth of resources and a greater continuum of resources that are needed. So although we're really proud to have tied a housing voucher resource to each person that's in permanent supportive housing, which really makes it easier and more sustainable for people to become permanently housed, we recognize that we also need to do a better job for folks that may be waiting to be placed in the program, and figure out how through 1115 Medicaid can address some of those gaps through bridge or through care management or care coordination strategies.
Hawaii has had a 1115 waiver since 1994. So a comprehensive waiver that gets renewed every 5 years. And for our program, it gives us, that is essentially how we operate our program. So we did not consider operating through a 1915 I, because that would be an additional set of requirements and reporting, et cetera, that would be in addition to what we already have to do and are required to do with our 1115 waiver. So it was a rather straightforward decision for us to go down the route of an 1115. And as was noted, we're trying to expand the services that we're providing and those are not available under a 1915 I.
I'll just say quickly too, Arizona also has operated off of an 1115 waiver since its inception, actually. But we have found a lot of opportunity for innovation through the 1115 waiver, as I mentioned. So historical design of supportive housing services to what we're working to implement under our new H2O approval. So from my perspective, I think just unique to me, the opinion of myself, the 1115 waiver has a lot of flexibilities.
So I'm going to ask you one quick lightning round question before we get to a quick wrap up. So what is one key lesson you would offer other states who are beginning this Medicaid and housing partnership, and also really thinking about the intersections of aging and disability as well?
Go into this with humbleness and an open mind. This is hard work. It's complicated work, but it is so critical that you spend the time to understand the complexities and the challenges of this type of work. But the reward, especially for individuals who are experiencing serious mental illness or substance use disorders, facing challenges of homelessness, it is life-saving work. So it is worth it to understand this is going to be complex and it's going to be hard, but worth it.
I can go. I would say, it was nice that Arizona had the director of housing position and 2 housing staff through our general fund appropriation. So probably look at how you can try to adequately resource your Medicaid agency to be able to do a lot of the upfront work prior to approval before you can access your H2O infrastructure dollars. The other thing is really you have to take a cultural look at making sure that everyone within the organization is ready for something like this, because they are Title 19 benefits. So it's not going to be siloed in any particular area. It's going to touch on everything you do within your Medicaid agency, claims, fees, everything. So helping everyone really truly absorb the motivation behind it to be ready to get to work is great too. What was the last question, Ryan? Sorry.
Oh, I think you're doing great. That was good.
Okay,
Yeah.
we're good. Okay, thank you for that.
And I'll just add that it takes a lot of time, and we're still working through better understanding, how do we prioritize people who are really medically vulnerable, recognizing that there's a lot of scarcity of resources, and that there are reasons why our continuum of care works the way that it does. So we're still trying to figure out how to bridge those and figure out how to address the needs of the most people, and to figure out how we can keep people safe and healthy.
Great. Thank you so much, Liz, Elizabeth, and Judy. That was all really incredible, important information and advice. And now I'm going to breeze through my last remaining slides. So if we could pull those up really quickly. We want to thank everyone for attending today. You can find a wealth of resources on partnerships in housing, health, and social care at the Housing and Services Resource Center website. So you'll see the URL here. And then next slide. And next slide. We're going to skip over. This is the first webinar in a 3 webinar series. The next 2 webinars, next slide, please, will be focusing on the important roles of local area agencies on aging and also centers for independent living within helping to promote housing stability. So please make sure you tune in and register for those webinars on September 24th and October 10th. And those links will be provided in the slides and dropped in the chat. And the next slide, we hope that you please will help us to continue to improve these sessions and complete a short feedback form. You can access it using the QR code there, and it'll also be dropped in the chat and emailed out afterwards. And next slide. And we also want you to know that the Housing and Services Resource Center is your resource center and here to help you. And when you hear about your partnerships, your innovations, what technical assistance needs are in your community. So please email us at hsrc@acl.hhs.gov. Subscribe to our listserv. We have over now 20,000 and growing people subscribe. So tune in for our latest updates. And with that, I hope everyone has a great rest of your day and week, and we look forward to meeting with you at our next webinar. And thank you to all of our wonderful TA providers who helped pull this together.